So we're going to continue with mycosis. And we left at cutaneous mycosis. I'm going to go to the next step. And most of the stuff over here is clinical. And you'll see a big change for the final exam because most of the final exam is going to be clinical, case-based. And Dr. Elise Gilbert, she's our clinical pharmacologist. She's going to come next week to teach you parasitology as well. So keep in mind, final exam, case studies, clinical questions, diagnosis, tests, and so on and so forth. So anyway, mycology also, that's why I wanted to finish up as a ASAP so I can give you the clinical cases and we can start discussing them. So let's finish the text part of it. So when we say cutaneous mycosis, we basically are talking about two important fungi. One is dermatophytic, the other one is non-dermatophytic. And dermo basically means skin, and phytic is like attracted towards skin. And there's two more clinical terms that we normally use, dermatophytosis and dermatomycosis. Basically, they both are cutaneous mycosis. So let me take the first one, dermatophytosis. Many of the diseases of fungi are pretty much complex, as we talked about the structure of them. And for fungi, keep in mind that the name of fungi, especially posted in the lecture, is something that you need to remember. Now, in this particular dermatophytosis, we talk of three important fungi, and they are trichophyton, epidermophyton, and microsporum. Again, you will see the theme if you pay attention. They are all related to skin. And we bunch them together to call them dermatophytes, and the clinical conditions are dermatophytosis. And they have the ability to cause infections in human and animals, and many times, remember those people who keep pets, you may be getting your fungal infection from your pets. So let's see what kind of immune response do you get. Now, as a rule, all of these fungi love keratin. So there's a protein there in skin, hair, and nails. And you can see that they are keratinophilic. Philic is like attraction. And they are attracted to keratin, and that attraction will cause lysis of keratin. And they have the ability to break down the keratin, and that's pretty much the most important clinical picture that you normally see. So when you look at the skin infections, you will see that dermatophytes, they invade upper and outermost layer of the epidermis, especially stratum corneum. And if you remember the different layers of stratum corneum, for some reason, penetration below the granular surface of epidermis is rare. So that's an important aspect for you to know. And as I said earlier, since skin has keratin, hair has keratin, nails are keratin, and they are embryologically developed from the same germ layer, so this fungi has an attraction for causing infection in all three forms. As we discussed the other day, dermatophytosis is also called a ringworm. And when we talk of worms, keep in mind that parasitology will also talk of worms, but those worms are actually worms. But in this case, this is I wouldn't say a misnomer, but this is basically the immune response, the inflammatory response that seems to form a ring form there. So if you look at the types of dermatophytosis, especially ring form, the classification is based upon which organ of your body gets that fungi. And you can see, we also call it tinea. If you go over the counter, you look for antifungal drug, you will see tinea, very common theme among the creams sold there. So tinea, and then again, depends upon which part of the body is involved. If it is capitis, it's going to involve scalp, eyebrows, eyelashes. Barbi for the beard, corporis for smooth and glabrous skin. Cruris for the groin, very common. Pedis is for the foot. And inguinum Onychomycosis, there's another term I want you to keep in mind. Onychomycosis means nails, because nails, the problem with the fungal infection of nails is that when it gets to your nail, it's pretty stringent, it's very chronic, it's difficult to treat, and cause a lot of problems to the nail. Now, the clinical picture again will depend upon the host reaction and also depend upon the site of infection. So, for example, if you pay attention to this part, you can see that of all the fungal infections that we get, and let's pay attention to the one on the left-hand side. So if you look at the Tinea piedra basically gives you like a whitish black kind of a picture. Trichosporon, again, you will see quite a few creams out in the market, trichophore. So you see the term used, trichophoron. And for cutaneous mycosis, you can skin hair and nails, epidermophyton, microsporum, and trichophyton. And we just ended candida as well. I'll discuss candida because candida also causes deep infections as well. And this is one of the commonest things that we especially see in females. Fungi also have an ability to go to cause infections of the brain. You can cerebral chromomycosis, and then again nasal parts, especially the turbinates of nose, and again skin, especially hairy skin in males. It goes for lymphatic pathway, lymphocutaneous. It can also appear on the front of abdomen. It can also appear to the genitals, especially anal canal, tinea corporis, and Eumycetoma. Remember we talked about mycetoma. Does anybody remember which bacteria will cause mycetoma? Does anybody remember? Actinomyces. Actinomyces. Remember I said actinomyces, mycetoma. The other mycetoma in this case is called Eumycetoma because it's a eukaryotic kind of a cell, especially fungi. And that's a differential diagnosis you have to keep in mind, and many times very common question asked. Again, you can see from here clinical presentation, depending upon which site is involved, you pretty much see a different name of that particular fungi. So all the way from scalp, hair, face, beard, glabrous skin, groin, hand, foot, and nails. You'll also see that most of the fungal infections tend to grow in areas which are moist and areas which basically are not open. So they are like a little bit kind of squeezed in, and these are oily, especially the web of the fingers. Those people who have a configuration that their toes are pretty much tied to each other, they will form this, especially athletes who's more than anybody else. So Tinea unguium, I say onychomycosis, important. And again, keep in mind that fungi basically are #1 in the market in terms of non-FDA approved drugs which are there over the counter, and people kind of tend to, I don't know what do they use, but they pretty much are available because everybody cares for the skin, hair, and nails. Now, let me talk about some of the aspects. For example, hair. I mean, I'm not going to teach you anatomy and physiology of the hair, but again, remember that the structure of hair in the skin, the shaft, the medulla, and the different kind of epitheliums which are surrounding, and the cells which are surrounding hair, there's something called healthy hair. Something is called broken hair. Right? It's pretty much common if you look at different types of shampoos that we have. But keep in mind that your hair basically are not dependent upon your hair care or your shampoo or whatever. It also something to do with your genes, genetics as well. So something that determines. Then also depends some of the psychological conditions, your level of hormones. For example, male pattern of balding, female pattern of balding, cancer pattern of balding. And then again, there are fungal infections. So you can see androgenetic alopecia. So this is like, the sites, a male pattern of hair loss because of androgens. And that is a retraction, frontal and thinning of hair, and then you can see trichotillomania. So trichotillomania is a psychological disorder where people, when they get depressed or they are in that kind of a situation, they do hair pulling. So they will pull, and you see some people playing with the hair, pulling it out. So that kind of happens if it happens in male. That's a psychological condition. We consider that as a part of mania. Okay? And you can see this happens, hair broken at the various levels. So if you look at the hair pattern of these people, hair are broken at different levels. And then again, you can see some other conditions which also cause male balding, because that's a big industry. And it's so funny, sometimes there's a big industry to remove the hair, there's another industry to put the hair. So hair transplantation. You can imagine they have to transplant each and every hair separately. So you can imagine how much time and how much money is going to be involved. But anyway, tinea barbae, caused by tinea verrucosum, again because of the shaving area, because of the injury being delivered by the sharp blades. The skin is continuously being shed off, and people, because remember, many a time if there are breaks and cuts, any injury, and people may have a little bit of inflammation there, that gives this tinea a chance to go and invade and cause problems. And that happens especially in the shaving area for males on the face. Tinea rubrum, cause of onychomycosis, one of the commonest causes of onychomycosis. And many times, especially for infections of the nail, we call it discoloration. So you will see discoloration in nails, and you can see on the top, that is coming from tinea rubrum. I would advise you, if you ever have a little bit of problem with the nail, get it treated ASAP, because if you delay it, it's going to stay for the rest of your life. It's very chronic. No cream is going to work on it. Whatever is there over the counter, nothing is going to work. I can assure you that. And then you will end up with taking oral antifungal, and it has a lot of side effects. It's expensive. It has a lot of side effects, and there's lack of compliance there. Okay, so that's like for those of us who really care about the nails. All right. So I told about the ringworm pattern. Again, this is the inflammatory response. I'm going to show you some picture. So this is how these cells keep on. It's not a granuloma, but the response usually is in concentric. It's like you throw a pebble into the pond and you generate the Whipple effect. So that kind of an effect comes, immune response, and that basically is responsible for the skin response, starting from erythema, which is redness, and then again, if you remember a slide which I showed you in the skin, where there's going to be a papule, a pustule, a vesicle, or different levels of skin lesions that you normally see. So if it happens in the hair, for example, so keep in mind, hair also will have inflammatory response. So you see the cells around the hair will respond in terms of, it may look funny to you, I mean, we consider hair as a dead tissue. That is correct, right? But again, it has this continuous ability to regrow. So that doesn't qualify for it being dead. It has a base and the cells grow up. The other common thing you will see that happens especially for infants because of diaper rash. That again is a fungal infection. And those of you who have seen that for the baby's diaper rash, this also happens to chronically bedridden patients, senior citizens in the hospital. They have to put on the diapers. But it also happens to both male and female in terms of the perineal area that you will see a classical pattern of the ringworm. And I think colors are better in your PowerPoint presentation that you may be looking at in your slide as compared to what I have over here. I want you to pay attention to the extreme right slide, and you will see a typical pattern of the rings. So that's typically a ringworm. It is not a worm, but it's an inflammation that happens, painful, and then it kind of spreads. Again, the structures, ring form, it can be a small little ring or it can be a huge little ring. Now, when you talk of dermatophytic mold, so remember that many a time if you were to grow it in the culture, it grows as macroconidia or microconidia. And if you remember the first lecture, I said these are little kind of those spores or those little birds that basically scatter off. So they are there, they scatter off, and then they cause infection because many a time they will embed in your clothes, they're embed in your fomites, your beds, anything that comes in contact with you. So we grow them in culture. And again, if you remember when I say culture, does anybody remember the name of the culture media for all fungi that we grow our fungi in? Sabouraud's agar. So Sabouraud agar is something that you have to make sure that you remember. As far as epidemiology is concerned, you can see that it's worldwide distribution, and it can be transferred, again, from person to person. And we did not discuss some of the diseases. We discussed bacterial, viral, STI infection, but since we didn't get time, I don't even remember if I gave you the STIs which were fungal or parasitic. So I'll talk about some of the diseases which are also transmitted because of the contact of the genital area in STIs. And I'm pretty sure Dr. Gilbert will talk about the parasite that basically also represent one of the STIs very common in this country. So you can see that these particular fungi can remain viable in desquamated skin. Desquamation means shedding off. Squamous is a layer of the skin, so desquamation. Many times you go to the, this airplane and they sometimes use the word deplane. Say, passengers will deplane. So de-loss basically is coming from the French word, so we use that a lot of time in pathology, desquamation. Right? So this means the normal squamous layer of skin is going to be shed off. And again, if it's in your hair and hair is falling off everything around you, so you are basically transferring that to other people. It comes in both sexes, all ages. And again, you can see tinea capitis, the tinea of the eyes, face, and the scalp is very common in prepubescent children. And again, you will see many times, especially acne and some of the hormonal changes that we normally see in the skin. Tinea cruris and tinea pedis are primarily diseases of the adult males, again, because of the groin infection and because of the moisture in the perineal area. When we look at the virulence for these infections, you have to keep in mind that if something is transmissible, so you usually take into account school children. So you will see tinea capitis in school children because they are small and they get together in a place. But other than that, 80 to 90% is from tinea rubrum and tinea metagrophytes. So these basically are two important. So next time you go and want to buy an antifungal cream and you look at the fungi mentioned on that bottle or cream, you will see these names there: tinea rubrum and tinea metagrophytes. And especially those of you who are still struggling to fight athlete's foot and they keep on using different kind of antifungal drug and nothing works, so you may want to go and find out what actually is growing there so we can treat that. All right. Now, as we discussed earlier, that the clinical picture depends upon the site of involvement, and there are some other important things that it also depends upon inoculum size. What it means is that what is your exposure, how much of the fungi are you exposed to? And then also depends upon your immune status as well. So many a times, for example, you will see people who get sick. So they may have oral thrush. You have candida infection of the mouth because of their immune system going down. And if you remember HIV as well, many a time the presentation is fungal infection. Your immune system is good enough to take care of your fungi, but if you are struggling and you have a chronic debilitating disease, or you are taking steroids, for example, and steroids will bring your immune system down, so you may be prone to fungal infections. So that's important. Okay, a little bit about the hair. So you can look over here that we basically got 3 types of infections of the hair. I don't know, did we ever go to a skin specialist to find out whether my hair is infected or not, but you can see hair get infected. And we have ectothrix, endothrix, and phavic hair infection, and that is a true actual electron micrograph, which you will see a shaft of hair, and actually you will see the fungi growing on top of it. So they do the hair scraping and look under the microscope and see that particular set of fungi. So you can see on the topmost, which is ectothrix, is like surrounding it, and then there's endothrix, which is inside it, and then again you have a phavic one that's growing at the base of the hair. So you may be losing your hair, or thinning of hair, or discoloration of hair, or breakage of hair, because your hair may have a fungal infection. And many times, some of the shampoos, I believe, especially the expensive one, may have an antifungal over there. Normally, antifungals are expensive. They will not put it in every shampoo. And we did talk about the shampoo for dandruff. What was the name of that? Selenium sulfide. So selenium sulfide basically is a very specific shampoo. It comes as a brand name as well, so that you want to use if you have dandruff. Now you can see from here arthoconidia. So you see the hair shaft, and you will see a typical ectothrix of the hair infection caused by M. canis, and then you will see those tiny little dots that you shed off. So if your one hair gets infected, it's going to infect all your hair. Because I remember when I was myself rotating in ophthalmology for eye infections, many times people have inflamed lids, and they tend to lose the hair of the eyelids, and they get kind of like sticky and mushy. So we found out that those of patients who have dandruff, so dandruff keeps falling on the eyelids, and that causes infection over there. So instead of treating their eyes, we treat their hair, so that falling off doesn't take place. But you can see those tiny little fungi. They are there. They are called arthoconidia. They are called arthoconidia, and they can be dispersed off in atmosphere. Okay, Tinea capitis, M. canis again, causing baldness, very specific area, usually circular area, and Tinea nigra. So Tinea nigra, because normally you should not have any discoloration on the arms, on the palms, but you this kind of a darkish, blackish, brownish kind of a thing. Over here, so if you look at it, it may seem to you naive, it may seem to you very benign, but if you scrape it off for skin biopsy, and you will see over here those little tiny hyphae. So there's a like little bit of hyphae that can be shed off. Just if you take a flower and blow into the flower, you see all those things spreading out. So that actually happens in fungi, so it can be transmitted to other people as well. Again, I'm going to present it over and over again, but I want you to keep in mind, for all lab diagnoses for fungi, we do direct microscopy. We take the skin, hair, or nail sample, and we want to put a drop of 10 to 20% potassium hydroxide and put it on the glass, and you can actually examine yourself as well. It's pretty simple. Or what you can do is that you can do the scraping and use a special dye we call calcoflower white. Calcoflower white, very commonly used, and that will give you better results. And then again, you can also grow these fungi on saborods, agar. Sometimes we add antibiotics, sometimes we do not add antibiotics. The reason being, just want fungi to grow, we don't want the bacteria to grow. But the problem for fungi is like Mycobacterium, it takes a little bit of longer time. So from 7 to 28 days. It's pretty much long time in terms of their gross appearance. And then again, you want to look at their nutritional requirements because you want to stop that and you want to come up with the drugs that are there to stop the fungal growth. Okay, so you'll see typically, I repeat, direct microscopy by 10 to 20% potassium hydroxide, calcoflower white, and then saborods, agar for almost all fungi. Now again, for treatment part, remember, we have not been asking you much other than the basic concept for bacteria and viruses and immunology, but this part does involve treatment because it's clinical as well. So this is about time that you start memorizing the name of drugs as well. So in this case, there are two types of antifungal drugs that we need to know. One are topical for skin infection, and again, oral. So if you look at the list of topical ones, again, I gave you an earlier slide, they all are azole compounds. They are azole compounds. So next time, again, if you go and buy yourself a cream, you will see they all end with azole. Miconazole, clotrimazole, iconazole, thiaconazole, itraconazole. So they are different names, different types, but they are all azole compounds. And then we have terbinafine and haloperin. There's some new ones which are coming up. And many times, classically, for classical dermatologists, they still think that you'll see sometimes they put that nasty kind of the dyes over there that doesn't look nice on these fungal infection, but they use it. Whitfield ointment is there, benzoic acid and salicylic acid. And then again, they have an antifungal activity. And those of you who have had a chance to go to dermatologists, and you will see that most of the dermatologists have this tendency not to go for the over-the-counter drug. So they will make their own prescription, and they will send it to the chemists and pharmacists, and they are specially made. So they pretty much have, like I would say, a cocktail of quite a few things. As far as oral antifungal drugs are concerned, again, they are griseofulvin, very important, itraconazole, fluconazole, and terbinafine. You can see some of them are used both. They can be used to a lesser intensity or lesser concentration, 1%, 2%, 5, 10%, and then again, they can be used as oral. And some of them are more rapid in action as compared to other. And as I said earlier, onychomycosis, if you have nail infection, everything fails, and you want to go for oral therapy. And I'm not going to teach you the side effects, but I can just give you a rough idea that oral antifungal is not something that you want to take. Some of the, like for example, some of the oral drugs will give you that metallic taste. So sometimes the compliance of patients is not good. If you want to tell them you have to take 3 tablets per day for 2 months or 3 months, they will give up on that. It's just like we talked about anti-TB treatment, in which I said the DOT is a direct observational therapy. So the health professional will make sure that the TB patient takes all those bunch of tablets in front of you. You want to see, observe it, because patient is not going to take it. And 6 months and 9 months is pretty much a long period. Okay? And again, it's expensive as well. So subcutaneous mycosis is the next one. Uh, Again, I've tried my best just to pick up those fungi that we normally see in clinical practice. And I was talking to Dr. Elise Gilbert yesterday, and she also told me that of all the parasites that we normally see in clinical practice, we'll just limit ourselves to those that are common and those that we normally see. So that will be a good guide for you and good training for you. So the main subcutaneous fungal infections are Lymphocutaneous Sporotrichosis. And again, if you pay attention to these names, they speak of a problem as well. They speak of pathogenesis as well. So you can see lymphocutaneous is going to go for lymphatic system, it's going to go for skin. And sporotrichosis, chromoblastomycosis, Eumycotic Mycetoma, I told you about actinomycetoma, subcutaneous zygomycosis, subcutaneous phi hypomycosis. So these are some of the things that we normally see in clinical practice. And you will wonder, why am I talking about that? Because you may not have heard about that. So that's a different world out there. But if you look at the incidences, some of the incidences are pretty much high in terms of some specific areas, especially in US. And I'll discuss that in detail. Pathogenesis, you can see subcutaneous lesion as a part of their disease process. Remember one of the slides I showed you that any subsequent deeper fungal infection will be also taking into part the previous one. So superficial, cutaneous, subcutaneous, they will be lumped together because fungi has to cross all those layers to go to the deeper portion. So you can see from here they have this ability to involve the deeper layer of epidermis, subcutaneous tissue, and we do see them clinically as something pertaining to the skin. That's why we call it subcutaneous lesion. And normally, exceptions are everywhere. We don't see them crossing into deeper part, and very rarely, unless you are HIV patient or unless you have an immunodeficiency or you have your immune system completely knocked off, you should not see a term that we call systemic mycosis or endemic mycosis, okay, or opportunistic problems. Again, the problem with the skin infections are they are chronic, insidious, suggesting to you very resistant, coming over and over again. You just finished the cream, you had 2 months of application, you just had 3 days for 1 week or 2 weeks, and it comes back again. So that's what the problem is. So we are still struggling to find out a good antifungal therapy because of the refractoriness of these infections. So we need to do a little bit more job in terms of looking at pathogenesis. Epidemiology, again, lymphocutaneous is also called sporotrichosis, and the causative organism is Sporotrix schenkii, and that pretty much is the commonest that we see. The interesting thing is that they are considered as a low pathogenic potential. So they may be low pathogenic potential for you because you did never come across soil, wood, or decaying vegetation. But if you happen to be a farmer, if you like gardening, if you like roses, all these kind of special, your commitments, special hobbies may prove to be increasing that pathogenic potential. So you need to, we call it occupational hazard. So this means you have to be exposed to it. For example, I gave you an idea, if you have a hobby of gardening or wood gathering, so you may get this disease. You have to be careful. This is a classic lymphocutaneous form of sporotrichosis. So what is showing to you is that you're plucking the flowers and you just got a thorn, or you just got that infection over there on your hand. And if you know your physiology and anatomy, the lymphatic system goes over here, and you can see across the length of lymphatic system, you will see these fungi appearing in terms of causing lesions. So that's what we call classic lymphocutaneous sporotrichosis. So you can see that. So the moment you see a person, you ask the person, what do? He will tell you that I'm a gardener, I'm working in farms, and you see this picture. Sporotrichosis. The sporotrichosis, again, is a important aspect. We call it a rose gardener disease as well. Those people, and remember many times, if you look at epidemiology, it may be rare, but we see them. Because why do we see them? Because we work in hospitals. Other people may not see them. So it's rare for them, but may not be rare for us. So sporotrichosis of the leg, you can see a typical fungal infection that will cause those people who handle roses. So you can see very mild form on this person over here, and very severe form on the right-hand side where the lesions get deeper. So lymphocutaneous sporotrichosis, this is how the clinical picture looks like. And as I said earlier, causative agent is Sporotrix schenkii, which is a dimorphic fungus. So what is a dimorphic fungus? Sorry?
Does it have two phases?
What are those phases? Size and shape are not phases. I told you the fungi come either in mold or yeast. They are either mold or yeast. So if they come in both, there is some temperature they are mold, and other temperature they are yeast, we call them dimorphic. Very important concept that you have to have. Okay? And most of the infections in human are caused by dimorphic. And you can see from here, at room temperature, Sporotrix schenkii grows as a mold, and at 37 degree in the tissue, it grows as yeast. That's what it is. So if you change the temperature, it changes the shape. That's what the problem is. So if you look at the morphology, it is a thermally dimorphic. It's very small. It looks like a plant. And then again, if you want to look at the yeast form, we call it typical cigar shaped. So it's like a cigar shaped. And I think I'll maybe tonight I'll post you some of the differential diagnosis. So I've got huge charts for you to prepare for that, because it may look very simple to you when I'm teaching them individually, but by the end of the day you have to do contrast and compare. So that's important for you to know. And yeast form basically are rarely seen in histopathological examination of the tissue. So if you take the tissue out, you would not see that. You would see the other form. And if you look at the mold phase, so mold phase is how it looks like over here. So you can see a typical plant-like thing, and with all those tiny little dots being shed off. So that's a typical of Sporotrix schenkii. Again, very common in warmer climates, and you can see North and South America, it's there, especially in South America, Mexico, Brazil, Uruguay, Peru, Colombia. Outbreaks are there, especially, as I said, occupational health hazard, people working in forest, mining, gardening. The classical infection is traumatic injury. So you just get pricked by a thorn, or you come across a soiled vegetable or organic matter contaminated with the fungi. And then again, zoonotic transmission from the animal, armadillo hunters. Does anybody remember what other armadillo will give you in terms of infections? Leprosy, Mycobacterium leprosy is also, especially in Texas, armadillos are known to transfer that. Then again, cat-transmitted sporotrichosis, we normally don't teach you the fungal infections that you get from your pets. But again, as a rule of caution is that if you want to have the pets, dogs and cats, you have to make sure that they have an insurance and they pretty much are covered for all these kind of infectious diseases that can come to your kids. Lymphangitic sporotrichosis, that's another form that again comes from extremities, trauma to the extremities, because you either walk on vegetation or touch vegetation. So that's the point when you talk of extremities are involved. So what happens is that the moment you get initial trauma, and within weeks of the primary lesion, you will see a typical painless subcutaneous nodules that are coming from the primary inoculation site all the way where the lymphatic drainage is. And you know the rule of lymphatic drainage is most of the lymphi tend to drain upper part towards your armpits, your axilla, and the lower part to your perineum. And then they all get together into your abdomen, and then you have thoracic duct, and thoracic duct will empty into the right side of the heart, and then it becomes circulated with the blood. So typical lymphatic drainage and lymphatic process in terms of the lesions that you normally see. And again, as I said earlier as well, that once you see these kind of ulcerative lesions, you want to make sure that the two important bacteria for differential diagnosis. So if I ask you what is the differential diagnosis of a fungal ulcer, the answer is mycobacteria and actinomyces. So they also look the same. So mycobacteria and actinomyces are something that you have to keep in mind when you want to look at those draining sinus and ulcers that you normally see. As I said earlier, treatment in this case is a little bit weird because especially in Africa and even in this country, for lymphocutaneous sporotrichosis, we give oral potassium iodide in saturated solution. That again is low cost, and it's still considered as a favored option. And you have to take it for 3 to 4 weeks, but problem is that you have a lot of nausea and your salivary glands will enlarge. But you have to kind of pay the price, that trade-off in terms of getting treated. In this country, we go for itraconazole, and if you, we'll keep on increasing the dose so that you get rid of that particular fungi. But if you don't respond to a lower dose, we'll give you a higher dose. And then we gradually move on from one drug to the other drug. Especially in Brazil, where there is some of the cases they see, and they have shown that if you apply heat to that particular area, that could also be effective. So if I tell you, if it's a fungal infection and you apply, in some of the clinical cases will be like that. So you'll be asked this question in the final. So if there is a fungal infection and you apply heat and the person feels better, so what do you think is happening in terms of pathogenesis? What's the idea behind it? What's the critical thinking? Yes, I just told you actually. I just told you. So this is where you need to kind of have that concept that most of the fungal infection that we get are dimorphic. So they exist in mold form at one temperature, and they exist in yeast form in another temperature. So if you were to apply a heat, so that will change the nature of that fungi, that it will switch on from yeast to mold or mold to yeast. And you never know which one of these forms is actually causing the problem. Does that make sense? So that's where it's coming from. Eumycotic Mycetoma, again, it is called by true fungi as compared to Actinomycotic Mycetoma, which is also considered a mycetoma, but basically is bacterial. Okay? And these fungal infections, especially Eumycotic Mycetoma, I don't have that picture, but if you Google it, it's like pretty nasty, kind of a huge ulcer, especially on the leg, Eumycotic Mycetoma. And then if I was to ask you pathology of mycetoma, this is a localized chronic granulomatous infection process. So that is basically a chronic inflammatory response that even you get in mycobacteria, in this case, where cells keep on coming and dying in terms of fighting off that particular infection. And then they will try to wall off. The objective of granuloma is to wall off the causative organism so that it doesn't spread. So that's the whole idea for the ringworm infection and so on and so forth. If you look at these abscesses, and you will, under the microscope and even visually, you will see fungal hyphae, those little drops, and they basically are known as granules or grains. So they appear like small little grains. And especially for Eumycotic mycetoma, they are a little smaller and they appear like black or pale or white green, depending upon what is the causative organism. And basically, they are present especially in low rainfall area, Africa, Middle East, and men are more affected than women. What could be the reason? What do you think could be the reason in epidemiology if I tell you for this particular mycetoma, men are more infected than women? Again, a critical thinking question. Louder? Correct, simple, very good. Simple. They work outside in the field as compared to women. So that's the logical, simple answer, and that actually is the correct answer. So whenever you're asked something, think of the common thing that makes sense and then move on from there. That exactly is the case because this is occupational hazard, and this happened to those people, especially who work in those areas. And to date, most of these mining and most of his vegetation and gardening, for most of the cases, are men. That's where you normally see that. So think of these simple things before you jump on to the more complicated one. Mycetomas are not contagious, so that's a good thing. If you look at the clinical picture, again, the most important thing for these, that they are like ulcers, there's inflammation, they usually start with a very small, they are painless. So they are painless. And then again, once they develop deeper, they have a sinus. Sinus is a opening between the actual lesion hidden in the body talking to outside. So like there is a tract there we call sinus. So that's where fluids, especially watery, pussy, starts oozing out. So that's what sinus means. And it can affect muscles and bones. It can be hematogenous or lymphatic spread. And then technically, question is if something goes into the blood, it can spread anywhere, but we do find it as a rare consequence. Lab diagnosis, they look at those grains. I told you the black and white and gray kind of grains. They take a sample from the sinus of the fluid and examine. And then they can also look for a deep surgical biopsy. How do you treat it? Unfortunately, is unsuccessful. So what happens is that if you have a chronic inflammatory lesion and you try all your antifungal drugs, oral, and they fail, and the only choice that you are left with is an amputation. So unfortunately for this particular Eumycetoma, amputation is the only definitive treatment. So that's considered as a very important aspect for the management of these cases. And again, keep in mind, it's not easy to make that decision to ask a person to be ready for amputation. Have you heard of something called phantom limb? Right? So you can imagine everything is expressed in your brain. So there is a cortex, everything is there. So all your different parts of the body are registered in your brain, and there is a sensory cortex and a motor cortex. And even if you remove that part, it still is represented over there. So people will have this feeling that it's still there. So that kind of a phantom feeling comes. And that phantom feeling basically is a cortical function. It's a cortical function. So the important thing over here is because of the quality of life of a person, if it's really get very severely inflamed, then of course you can ask the patient to be prepared for the prosthetics, and then depending upon the circumstances you can go for that. But as far as we are concerned, we want to make sure that we are not looking at actinomycotic mycetoma. Had it been a bacterial mycetoma, then of course we would go for medical therapy because that's a bacterial in nature. So fungi are more, I would say, surgery wanting kind of microorganisms as compared to bacteria. Okay, so I'll stop here and